Context: changing requirements demand new leadership learning.
How does Austria organize public health?
Like most industrialized countries, Austria is confronted with permanently rising health expenses. In 2007, Austria invested 10.3% of GDP in the healthcare system and was third place in the EU comparison. Habl, Bachner, Klinser, and Ladurner, 2010. Approximately 76% of the expenditures on healthcare in Austria are obtained from the federation's public funds, the municipalities and the social insurance carriers. The rest is financed by private households and private insurance companies. The majority of the investments in healthcare is dedicated to inpatients, ca. 33%, whereas the holding for outpatients seems relatively low in comparison, 18.2%. Austria has a high rate of hospitals, beds and doctors. In 2007, Austria was at the peak in the EU comparison, having about 28 hospital inpatient stays per 100 inhabitants, average length of stay 5.7 days, Habl et al., 2010. In addition to contract physicians, roughly 800 outpatient clinics mainly take care of outpatients. The tasks of public health care in Austria are split among the federation, the states and the municipalities. Even though there are numerous initiatives to improve the coordination and cooperation in health care, for example, nationwide and regional structural plans, division in competencies complicates fundamental reforms. That is evident inter alia in the closing of public hospitals, which is hardly enforceable politically. Public and private hospitals as well as other organizations which provide medical and care services, such as outpatient clinics and diagnostic centers, are under high competitive and changing pressure due to increasing life expectancy, high supply density and economizations in the public sector. In numerous states and municipalities, public hospitals have been hived off into individual companies. Even if a spin-off is successful, it still underlies political influence due to the ownership structures and the committees' occupations, for example, of the supervisory boards. These changes in the health sector result in new requirements for leading healthcare organizations as well as an urgent demand for new leadership roles and leadership learning.